Hello, my friends. I'm Dr. Rachel Storms, and today I want to give you something most people never get in a short doctor's appointment. A complete, honest explanation of how Lisinopril, one of the most prescribed medications in the history of modern cardiology, can quietly damage your kidneys after 60 if you continue taking it the way you took it at 45. Lisinopril has saved millions of lives from heart attacks and strokes. The evidence for its benefit is unambiguous. But the rules for taking it change as your body changes, and the changes that happen in your kidneys after 60 are exactly the changes that turn this life-saving medication into a potential kidney toxin if a few specific habits are not corrected. I want you to understand something at the start. I am not telling you to stop your medication. I am telling you that there are specific patterns of use, hydration status, and drug combinations that turn a safe and beneficial medication into a dangerous one. And these patterns are extraordinarily common in adults over 60. By the end of this video, you will know exactly what those patterns are, how to recognize whether you are at risk, and what to do about it starting today. Stay with me through the entire video because the third and fourth issues I cover are the ones that most consistently send patients to the hospital and that are also the most easily prevented. Let me start with what is changing in your kidneys after 60, because this is the foundation that makes the rest of the video make sense. The concept I want you to understand is renal reserve. Your kidneys at the age of 20 have an enormous functional reserve, meaning they can handle large variations in blood flow, hydration status, and medication exposure while still maintaining adequate filtration. As you age, that reserve gradually declines. Starting around age 40, you lose approximately 1% of your kidney function each year. This is a natural process, not a disease. By the time you reach 60, your kidneys have meaningfully less reserve to handle the various stresses they face. By 70 or 75, the reserve may be quite limited, even in people who consider themselves healthy and who have never been told they have a kidney problem. Now, here is why this matters specifically for Lisinopril. Lisinopril is an ACE inhibitor, which means it blocks the enzyme that produces angiotensin II, the hormone that constricts blood vessels and raises blood pressure. The mechanism of action that lowers your blood pressure throughout the body also has a specific effect inside the kidney. The kidneys filter blood through millions of tiny structures called nephrons, and the filtration process depends on a pressure gradient between the artery entering the nephron and the artery leaving it. In a healthy kidney, the exiting artery, called the efferent arteriole, is held in a slightly constricted state by angiotensin II. This constriction maintains the filtration pressure that drives waste products from blood into urine. Lisinopril, by reducing angiotensin II, relaxes that exiting artery. The filtration pressure inside the kidney drops. In a young kidney with abundant reserve, this drop is absorbed easily and the medication's benefits dominate. In an older kidney with diminished reserve, the drop in filtration pressure can be too much for the system to compensate for, particularly under conditions of stress like dehydration or low blood volume. The result is what we call prerenal acute kidney injury, meaning the kidney itself is structurally intact, but it is not receiving adequate flow and pressure to filter effectively. You feel no pain. Your urine does not look different, but your creatinine, the laboratory marker of kidney function, is rising silently in your blood. I want to be very direct about something here. The number of patients I have seen develop prerenal acute kidney injury on Lisinopril is significant, and in the majority of cases, the problem was not the medication itself, but the conditions in which it was being taken. The patient was dehydrated. The patient had started a new medication that compounded the effect. The patient was taking ibuprofen for a flare of joint pain. The patient was using a salt substitute. The kidney damage was preventable. The patient and family did not know what to watch for. So let me give you what to watch for now. The first major error I see is dehydration combined with Lisinopril, and this is more common in older adults than most people appreciate. As you age, the thirst sensation becomes less reliable. The hormones that regulate fluid balance become less responsive. Many older adults are mildly dehydrated most of the time without recognizing it. Now consider what happens when this person takes their Lisinopril first thing in the morning after 7 or 8 hours of sleep without any fluid intake. They are dehydrated. Their blood volume is at its lowest point of the day. Their blood pressure may already be in the lower range due to the natural circadian dip. They take a medication whose entire mechanism is to lower blood pressure further by reducing filtration pressure inside the kidney. The kidney, already operating with reduced flow because of the dehydration, now faces an additional drop in filtration pressure from the medication. This is the exact recipe for pre-renal injury. Here is the rule I guess my patients. Never take Lisinopril without at least a full glass of plain water, ideally 8 ounces, and ideally consumed in the 10 to 15 minutes before you take the pill, rather than just to swallow the pill. This pre-hydration step ensures that your blood volume is adequately filled and your kidneys are well perfused when the medication arrives. It is a 30-second habit that prevents one of the most common medication-related kidney injuries in geriatric medicine. And if you have had recent diarrhea, recent fever, recent intense sun exposure that caused sweating, or any other event that may have depleted your fluid status, that is the time to call your physician and ask whether you should hold your Lisinopril until you have rehydrated. Continuing a full dose of Lisinopril through significant dehydration is one of the fastest routes to acute kidney injury that I see in practice. The second major error, and the one I want to spend the most time on because it is responsible for the largest single category of preventable kidney injury in this patient population, is the combination of Lisinopril with NSAIDs. NSAIDs are the non-steroidal anti-inflammatory drugs, including ibuprofen, naproxen, and several others. They are sold over the counter under names including Advil, Motrin, Aleve, and many generic forms. They are widely used for joint pain, back pain, arthritis, and minor injuries, and most people take them without thinking of them as serious medications because they do not require a prescription. Here is what NSAIDs do at the kidney level. The blood entering the nephron through the artery called the afferent arteriole is held open by prostaglandins, which are local hormonal signals produced by the kidney itself. NSAIDs work by blocking the enzyme that produces prostaglandins. While this is the mechanism by which they reduce inflammation and pain elsewhere in the body, it also has a direct effect on the kidney. The afferent arteriole, no longer held open by prostaglandins, partially constricts. Less blood enters the nephron. Now combine this with Lisinopril. Lisinopril is dilating the exiting artery, the efferent arteriole, reducing filtration pressure from the back. NSAIDs are constricting the entering artery, the afferent arteriole, reducing flow from the front. The kidney is being squeezed from both sides simultaneously. If a diuretic is added to this combination, which is very common because many patients on Lisinopril are also on a thiazide or loop diuretic to reduce blood volume further, you have what we call in medicine the triple whammy. This combination has been documented in multiple studies to dramatically increase the risk of acute kidney injury. The mechanism is straightforward and the clinical consequences are real. I have personally seen patients over 65 lose 30 to 40% of their kidney function over the course of a single weekend after taking ibuprofen for a knee flare while continuing their Lisinopril and diuretic regimen. The action I want you to take, if you are on Lisinopril, is to treat NSAIDs as essentially off-limits for routine use. The occasional dose of ibuprofen for a single isolated headache in an otherwise well-hydrated state is not the dangerous scenario. The dangerous scenario is daily or near-daily NSAID use for chronic joint pain or back pain. If you have chronic pain that requires daily anti-inflammatory medication, the conversation to have with your physician is not whether to keep taking NSAIDs alongside Lisinopril. The conversation is which pain management alternatives are safer for your kidneys. The options include acetaminophen, which works through a different mechanism and is much less harmful to kidney function. Topical diclofenac, which is an NSAID applied as a gel to the skin over a painful joint, delivers most of its effect locally with much lower systemic absorption and substantially reduced kidney risk. Physical therapy, weight management, and targeted exercise are non-medication approaches that often produce meaningful improvement in chronic musculoskeletal pain, and that should be part of the long-term plan. Your physician can help you build a pain management strategy that does not put your kidneys at risk. The third major error involves potassium, and I have discussed this in previous videos, but I want to emphasize it specifically in the context of lisinopril because the kidney implications are direct. Lisinopril reduces the kidney's ability to excrete potassium through its effect on the renin-angiotensin-aldosterone system. Under normal dietary conditions, this potassium retention stays within safe limits. The problem arises when patients add additional potassium loads, often through salt substitutes that contain potassium chloride, through high potassium supplements, or through diets that combine multiple high potassium foods daily. Salt substitutes deserve specific attention because they are often marketed as healthy alternatives to sodium, and many older adults adopt them without realizing what they actually contain. A teaspoon of standard salt substitute provides approximately 2,500 milligrams of potassium, which is more than the average daily intake from food and which exceeds the kidney's capacity to excrete when they are operating under the additional constraint of lisinopril. The result, over weeks to months of regular use, is the gradual accumulation of potassium in the blood, called hyperkalemia. Early symptoms are subtle and easy to dismiss: muscle weakness, fatigue, occasional palpitations, mild tingling in the fingers or around the lips. Severe hyperkalemia produces cardiac arrhythmias that can be fatal, and the kidneys themselves, struggling to handle the elevated potassium, may also be operating with reduced filtration capacity that goes undetected until a routine blood test reveals both elevated potassium and elevated creatinine. If you are on lisinopril and you have a salt substitute in your kitchen, the action is straightforward. Remove it. Do not replace it with another potassium-based substitute. Replace the practice of seasoning with salt or salt substitute with the practice of using herbs, spices, garlic, lemon juice, vinegar, and other flavor enhancers that do not load potassium. Garlic, oregano, basil, rosemary, lemon zest, fresh ginger, and quality vinegars provide flavor depth that often makes patients realize they were over-relying on salt out of habit rather than need. And if you have been using a salt substitute for some time, ask your physician at your next appointment to check your potassium and creatinine levels, specifically in the context of your lisinopril regimen. Let me also address the symptom recognition piece, because patients on lisinopril often experience early warning signs of kidney stress that they do not recognize as such. The signs include a decrease in urine output, particularly the morning void, which should be a substantial volume after a night of sleep, but which may be reduced when kidney filtration is impaired. Swelling in the ankles or hands that is new or worsening, which can reflect fluid retention from impaired excretion. Unusual fatigue that is not explained by sleep or activity. Brain fog or difficulty concentrating that has developed over weeks. Loss of appetite, particularly accompanied by metallic taste in the mouth, which can reflect the buildup of urea and other waste products that the kidneys are not adequately clearing. And in the specific case of hyperkalemia from lisinopril plus potassium loading, the tingling around the lips or in the fingers that I mentioned earlier is a particularly important early warning sign that warrants prompt evaluation. If you experience any of these symptoms and you are on lisinopril, do not assume they are aging. They may be your kidneys telling you that the current regimen is exceeding their reserve. Call your physician and request a basic metabolic panel, which is a simple blood test that will show your creatinine and your potassium levels and can be done same day in most settings. Early detection of kidney stress before it progresses to acute kidney injury allows the regimen to be adjusted and the kidneys to recover. Late detection often means damage that does not fully reverse. Now let me give you the protective protocol that integrates everything we have covered. First, request a comprehensive metabolic panel including creatinine, eGFR, and potassium at least every 6 months if you are on lisinopril and you are over 60. Annual testing is not adequate for this population. Twice yearly is the minimum, and quarterly may be appropriate if you have other risk factors. Second, never take lisinopril without a full glass of plain water consumed in the 15 minutes before the dose. Make this an absolute rule. Third, eliminate NSAIDs from your routine use. Have a specific conversation with your physician about pain management alternatives if you have chronic musculoskeletal pain. Fourth, Remove salt substitutes from your kitchen and replace them with herb-based seasoning strategies. Fifth, monitor your home blood pressure regularly and report any sustained reading below 110/70 to your physician. A pressure that low on lisinopril may indicate that the dose is excessive for your current kidney status and may be contributing to chronic underfiltration. Sixth, if you develop any acute illness involving vomiting, diarrhea, fever, or reduced food and fluid intake, call your physician and ask whether you should temporarily hold your lisinopril until you have recovered. This single practice prevents a significant proportion of the acute kidney injuries that occur in this patient population. I want to add one more consideration that is particularly relevant for older adults. The conversation about whether lisinopril remains the right medication for you specifically is worth having periodically with your physician. Lisinopril is excellent for many patients, but for some older adults whose kidney function has declined to certain thresholds or who have developed certain side effects like persistent cough, switching to a different agent within the broader class, such as losartan or valsartan, may be appropriate. These medications work on the same hormonal pathway but cause cough less often and may be tolerated better in some patients. The conversation is not whether to abandon ACE inhibitors as a class. It is whether the specific molecule and dose you are on remain optimized for your current physiology. Before I close, I want to be honest about why I made this video. Lisinopril is one of the most widely prescribed medications in cardiology, and it deserves its place in our therapeutic toolkit. But the routine appointment that prescribed it to you, possibly years or decades ago, did not have time to give you the geriatric framework I have just described. Your kidneys at 65 are not the kidneys you had when you started this medication. The rules that protected you then need to be updated for the body you have now. This is not a failure of medicine. It is a recognition that medicine after 60 requires precision and engagement from the patient that earlier in life it may not have demanded. Your kidneys are the filter of your life. The medication that was designed to save your heart can quietly damage them if a few specific habits are not corrected. Share this video with anyone you know over 60 who takes lisinopril or who takes any blood pressure pill that they cannot quite remember the name of. The phrase, the blood pressure pill, is so generic that most patients do not know which specific medication they take. But lisinopril is one of the most common, and the warnings in this video apply to a large proportion of those patients. Sending this video to them is a direct act of care. And if you want to understand the full picture of how the morning routine affects medication absorption and effectiveness, my video on the morning habits to stop when taking losartan, amlodipine, or metoprolol covers the daily timing piece that complements everything we discussed today. Watch that video next.